Okay, good morning to everyone. Thank you very much for this invitation to give this talk. My topic is embryology and anatomy of the Sellar region, and I think a good slide to start with this topic. It's a sketch of a fetus on about 8 weeks of gestation, and you see already at that time some parts of the brain already exist, like telencephalon, the hemisphere, diencephalon, mesencephalon. And also cranial nerves are already visible, and also the medulla. The start of the development of the diencephalon and cellular part already started in the 3rd week. And we have at that time 3 layers. We have that time oral ectoderm, we have a neuroectoderm, and there's some kind of a pouch, it's called stomodium. And in this stomodium is kind of a primordial cavity, oral cavity, that makes some kind of outpocketing to upwards, and at the same time, the layer of the neuroectoderm progresses downwards, and those 2 layers meet and create at some point the adeno and the neurohypophysis, and this pouch is called Radke's pouch, and after a while, there's some disconnection between the oral ectoderm and the neuroectoderm, and the neurohypophysis and the adenohypophysis is fully developed. You see, the adenohypophysis has some called 3 segments. It's the pars tuberalis, which is around the neurohypophysis. There is a pars distal and the intermediate part between the neurohypophysis and the pars intermedia. This is the cleft in the cleft, which we have heard in the talk before. The Radke cleft cyst may develop from this point. This slide is a bit more busy, but it shows you in this sketch this part, this duct. It's called craniopharyngeal duct, and along this duct, some remaining tissue from the pituitary, from the adenohypophysis can remain. It can remain in the cellar part, outside the brain, but in the cellar. It may remain also in the bone or in the pharynx, and it's called the pharyngeal accessory or accessory tissue, pituitary tissue, and has some clinical implication. It may have, and you have some residual pituitary gland tissue. In this study, they found out that this pharyngeal pituitary exists all over lifelong and in every individual, and it may also produce hormones. It's I make here a question mark because the staining was positive, but there is some hints that there is still some active active hormones can be produced, because in the past, for the treatment of metastatic breast cancer, they did this surgery. It's called hypophysectomy. So they took out the pituitary in total to control the metastatic breast cancer, and the patient improved because the hormones decreased and the patient got less symptoms. And also they checked the hormones before and after surgery, and they found out that in most of the cases there's still some remaining hormone production of the pituitary, and they think that probably this comes from this tissue, from this pituitary lobe tissue in the pharynx. And also, when you do in most of the patients, when you do a stimulation was still possible to get some hormone reaction. And also, when you see pathologies, we know all that we have pituitary tumors. They don't arise from the sella. They may arise from the bone or also even from the epipharynx. So it's possible that this additional anterior lobe tissue can make tumors. Of course, the most ectopic pituitary tumors are in the sella or in the sinus. sphenic sinus, but some may also arrive in the pharynx or even the clivus, like in this case. Craniopharyngioma is a topic for today, and this duct, this craniopharyngeal canal, they may dedifferentiate, and some craniopharyngioma, although most of them arise from this part. There are two parts of craniopharyngioma. This is the adamantinomatous type and the papillary type. This type occurs in all age groups, and this type more in the elderly. And some gene regulations or gene disturbances are described for both different types. And also, you see also from this part, other parts of they can occur everywhere basically, or in the cellular region, not just in this duct. So the tumor can also be some kind of ectoplastic or in other sites. The cellular anatomy, this sketch you have seen before of my previous speakers. It's probably some basic sketch to illustrate the pituitary or cellular anatomy. You see the pituitary gland, the chiasm, third ventricle, and also the sphenic sinus. And on the lateral, the cavernous sinus contains the carotid artery and the cranial nerves. The pituitary gland, to think how big is the pituitary gland in normal? We don't see this in surgery because normally we don't operate on the healthy pituitary. Sometimes it may have the normal size when you're looking for hormone active pituitary adenoma, but what's the volume in general? And we know that this may vary. But what you think, what is about the normal volume of the pituitary? Is this, let's say, something below 0.5 cc, something between 0.5 cc and 1 cc, or above 1 cc?
Well, it depends on age, right?
Depends on age.
Yeah.
And
you see girls with the balloon, right? Which is normal.
Yeah. There's something age dependence, that's true. And what else? What is also very well known? Gender. Women have bigger pituitaries than men normally. And what is in this study came out is that it has also depends of the BMI. So obese people has a larger pituitary gland. And the median volume is about 0.38 cc. This is a sketch, I think we all probably remember back from our medical studies, how the pituitary works and with the hormones. I think it's very well illustrated in this sketch. I took it from the internet, but it probably shows very well the function. When you want to test the pituitary function, sometimes you get a call from a family doctor, what should I take for lab values? Then I always mention some, but I always forget one hormone to test. And when we go through this slide, I think one of the most important tests are to take the basal cortisol, measure T4, T3, TSH is important, LH, FSH as well, and also testosterone. And prolactin, and you don't see here because it's hidden, it's the IGF-1 for the growth hormone. I think growth hormone itself you don't measure normally. It's not a routine because it's very pulsatile. And so as a substitute, I think IGF gives a good hint about the pituitary function. To remember, chromophobe, acidophil, basophil, tissue of the gland, I had to check again to remember which belongs to which hormone. Then you go back. So I just read yesterday. So it's ACTH, TSH, LH, FSH is basophil, and prolactin and growth hormone are acidophil. I'm right? I think so. Okay. What are the normal values in childhood and adolescence? This may vary. So I asked my pediatric endocrine in Chur, I would make a good sentence, just one statement about differences between children and other adults. What can we say? And he told me, don't say anything because it's too complex. So it may vary from age, from weight, and puberty. So I found literature that shows that, for cortisol, for example, and growth hormone, it may vary the normal range values. So, but I probably will hear in the afternoon probably more about this, which is a very interesting topic. Talking about cellular anatomy is always to talk about the sphenoid bone. And this is also a sketch from the internet, and also was related to a test for medical students. And I think when you go through these various points, you can I won't go through, but I think to just remind where the different parts are located, because the sphenoid bone is very complex. You have, of course, here the optic canal, you have the tuberculum, the Sella. 4 is the lesser wing of the sphenoid bone. This is the greater wing. This is the anterior clinoid, posterior clinoid, dorsum sellae. I have already checked the 9 is foramen spinosum, foramen ovale, foramen rotundum, and superior orbital fissure. This is from a view from above. And when you see this on the imaging, the sphenoid sinus, you see mostly various septae inside. This is one septa you see in all 3 images. It's a longitudinal septa in the sinus, and here you see multiple septa. I think for surgery it's important that you are aware where the septae are, because they can help you to they can bother you because you are not oriented very well, but it can help you to orient yourself. And but you need to know where they are, where they go to, and don't avoid any complications. And so when you go for the transsphenoidal approach, always study the septa to look where they exactly are. There is some study which gives you some idea about the sphenoid sinus, because not on all patients the sphenoid sinus is fully developed. In here it's all barely seen, and here it's just a bit bigger. But most of the time those types of development occurs. They call it like this. It's a kind of a conjugal, precellular, cellular, and postcellular type. And most of them, it's fully developed. But those, when you have encountered those patients with such a Sella, it makes surgery difficult, because you have to drill much more bone to access the Sella. This is a picture of a book I really can recommend. So Dr. Michel Rötlisberger left over this. He wrote a chapter about this in this book, and the anatomy is very well very well drawn. Really, it's a view to the Sella. You have here the cellular part, which is the plenum sphenoidale. This is the Sella turcica. This is cellular floor, and ST, what it is, I don't remember now. So when you see lateral, you see shining through the right optic nerve, left optic nerve, and the carotid artery. This is the cavernous part of the artery. And here is a paraclival part of the carotid artery. And here is the clivus, and also some kind of venous plexus shines through, and also septa, sphenoid floor. And this is what you encounter before you make the bony opening of the Sella. When you open the Sella, you see this. You see this is already from an anatomical view with the optic nerve, optic chiasm, already arteries are visible, the stalk, pituitary stalk, pituitary gland, and also some sinus here depict, and also the arteries. Some arteries are seen in this draw. Normally, we don't see this during surgery. Just when it starts to bleed, then it may occur that this artery starts to bleed. This is a picture, a surgical view, and this is already, everything was already removed. Dura was removed, bone was removed, and this is A2, optic chiasm, right optic nerve, left optic nerve, and through this goes to the third. So that's basically it for my part.